I'm going to speak about the rare and novel complication with dermal fillers. And I will try to do it as a Q&A. So this is a patient coming to your office 3 weeks after hyaluronic acid injection to the posterior temple. So what can it be? And again, it has been published by my group. And we call it non-scarring alopecia. And in our case, it was published after using the posterior temple lifting technique, which was published in 2020 by Sebastian Cotofana and his group, and was very quickly adopted by multiple practitioners. And this is my case. It's actually a good friend of mine. And she came to my office for mid-face, non-surgical mid-face lifting. So I used the posterior temple technique. I will discuss more a little bit more in a while. And then she called me the next day. Everything was uneventful. The next day, she called me saying that there is a little bit of discomfort on her scalp. Posterior temple technique, the injection is actually performed anterior to the tragus. So she told me, I'm not sure that it's related to the injection, and I'm very busy today. I will come to see you tomorrow. And this is what I found when I saw her the next day. Basically, nothing on the facial skin, but while looking at the scalp skin, I could see this levadoid rash. At this stage, the pain was quite significant. So I started to treat her by infiltrating the affected area with hyaluronidase. And as you can see, I used a significant number of units, 1,500 every 3 times at the same day, and then doing it again. And I kept doing it until she reported some kind of relief in the pain. Because once you see levadoid rash, do not expect it to disappear. So your only clinical indicator that you did something good is that pain becomes less severe. So as she reported that she is better, I stopped injected her with hyaluronidase, and we all were very happy until in 2 weeks, she called me saying that she has terrible hair shedding. And this was the course of her alopecia. You can see it here, and it got as bad as you can see here. And it took 1 year until a full hair regrowth occurs. And this is a case from Thailand, from another colleague, very similar, multiple units, multiple thousands of units of hyaluronidase. You see no skin necrosis. And yet alopecia started, and it was quite a significant alopecia, and hair regrowth. You see, after 6 months, the hair does regrow, but it takes a lot of time. So these are our cases published in the JAD case report 2023. So it was 6 cases, most of them induced by HA, but one was with calcium hydroxyapatite. What I do want you to see that the amount of the product was very small in some cases, like 0.5 ml of a syringe per side. So it's not a amount of HA related. And all of them were treated by hyaluronidase, so the skin was saved, no necrosis. So they did not develop scarring alopecia. If the scalp skin was scarred, the hair will probably not regrow. In all these cases, they had a full hair regrow, but it took almost a year. And this is recently published case. Actually, I found it it's from China, published 2025. Again, very, very similar course. So filler-induced alopecia, it's a very hot topic now in our profession. So a few words about the posterior temple lifting technique. This is how it is performed. 22 gauge cannula introduced anterior to the tragus superficially, and you can see all these publications actually glorifying this method. To tell you the truth, that lifting is very minimal. And the mechanism why it lifts the midface is the same mechanism why it can cause this vascular event, because the superficial temporal artery with this frontal and parietal branch that George so nicely demonstrated before, in the area of posterior temple, it runs in very compacted tissue. So if you inject a bolus there in this very compacted compartment, it will lift a little bit the midface. It has been shown that if you fan, you do not lift. If you inject a bolus, then you can lift. But this is exactly why you can affect the arterial blood flow, because this bolus can, even if it's not injected inside the artery, it can create extravascular pressure that will affect the blood flow, and this is the pathogenesis of this phenomenon. So first of all, I recommend to avoid using it, because as I mentioned before, you cannot decrease the risk by using smaller amounts, because it can happen with a very small amount. And the problem is, first of all, diagnostic, because the patients, you don't see anything. And the patients, when they started to feel something, they're not necessarily related to the treatment, because the pain is actually completely unrelated to the place to which, according to the patient concept, the filler was injected. So they will not always come and complain on it. If they come and you do not check the scalp, you will not be able to find anything wrong and to make the correct diagnosis. Now, even if you were successful to make the diagnosis and you inject enormous amount of hyaluronidase and you save the skin, the hair follicles are already affected and they enter anagen effluvium. Therefore, you cannot stop the hair shedding. If you did not treat it, you will have skin necrosis and then scarring alopecia, and the hair will never regrow again. So posterior temporal lifting technique carries inherent and unpreventable risk for vascular obstruction, and therefore should be abandoned. What is this? This actually started 4 days after filler injection in the frames of medical tourism. The story is the husband is going to another country for hair transplant. Meanwhile, the wife, who accompanies him there, is offered aesthetic treatment. After the hair transplant, they're coming back home, and then all this started with the patient. So we have to be very, very careful about cosmetic tourism. Usually people are going for cosmetic tourism to cheaper countries. So cheaper countries, the higher risk for unhygienic environment. So in this case, and this is one of the previous publication on Mycobacterium abscessus. Currently, I think, evidence epidemics of Mycobacterium abscessus infections following cosmetic procedures. So be very much aware of it, because to make the diagnosis, you need to take a culture and to ask the lab to use a specific media. It will not grow in the normal media. So you need to suspect, you need to ask, because you actually need to have not only the culture, but also the exact antibiotic sensitivity. And as George mentioned, usually double antibiotics are required to cure these cases. And this patient has been treated for 2 months intravenously until all the infection was eliminated. And then she was treated by me just to make her look normal again. What is this? Again, this is my patient. She was very happy for years, and then she started to develop this inflammatory reaction on her right side of the cheek. and she did not respond to any treatment. I was consulting ENT surgeons, and what they found at the end, the patient admitted that she's coke addicted. So always keep in mind, cocaine-induced midline destructive lesions are common. And the moment you have this kind of lesion, you have, first of all, cocaine induces destructive lesions in the bone through vasoconstrictive and caustic effects. And if you have oronasal perforation, you have a continuous flow of the oral and nasal flora to your implant, to the filler. So it's going to get infected and reinfected until full reconstruction of the face is not performed. And this is exactly what happened in this case. So always keep it in mind. If you have this kind of infection, young patient, high socioeconomic class, do not be shy to ask specifically about cocaine. And what is this? If you look in the infraorbital area, there are some plaques, whitish plaques. So we call it xanthelasma-like reaction. So far, 7 cases have been reported. I had 2 cases of my own. I did not report them. And the fillers are different. Hyaluronic acid, calcium hydroxyapatite, polycaprolactone. It occurs late after the injection of the filler, usually 6 to 18 months. There's not a good explanation why it does occur. Actually, there is not a good explanation why xanthelasma occur at all. But in this case, we call it xanthelasma-like reaction because the color is completely different. It's not the cholesterol, it's something else, at least in some cases. And I do suspect in most of the cases, as it happened to me, it was pre-mixture of HA with a little bit of calcium hydroxyapatite. I think it's like 10 or maybe more than 10 years ago. There was a very nice idea to decrease the risk of Tyndall effect by making HA less transparent. So it could be achieved by mixing a very small amount of calcium hydroxyapatite into the HA. And actually, it was a suspension, so they were not connected. So once calcium hydroxyapatite is there, in some cases, it actually can float up and then create this visibility of calcium hydroxyapatite, and this is why it's called xanthelasma-like reaction, and this is why it actually looks white. In most of the cases, so I stopped doing it after seeing 2 cases. I told to my patients in which I did observe this phenomenon, you are going to be the first case in the medical history in which xanthelasma will disappear by itself. So, and it's exactly what happens. So if it is related to calcium hydroxyapatite, do not do anything. It will go away by itself. While if the other fillers, you can use all the other methods to treat xanthelasma. Now, and this is the case that George just mentioned, intracranial penetration during temporal area injection with a filler. So we need, nothing happened because I spoke with Sebastian Cotofano regarding this case. It was a severe pain in the middle of the temple. There is the bone is very, very thin. So if you use a gunshot technique for temple injection, be careful. Temple is very challenging area, as you can see. So be careful. Do not press too much on the bone. In this case, it was painful. The physician did not start to deliver the product, so nothing bad actually happened, but it was actually good proof that you can penetrate the bone while injecting the filler. So just to conclude, because I think we did cover almost everything. So there are common and rare complications of botulinum toxin and fillers. Most of us are very much familiar with the common complications. Rare complications do occur and patients are getting very stressed when it happens because they also sometimes feel that the physician is not knowledgeable enough to make a diagnosis, to explain. In most of the cases that we mentioned, actually, especially with botulinum toxin, no treatment is needed. It's wait and see and support your patient. While when we're talking about filler-induced alopecia, treatment is necessary as soon as possible, and yet we need to support the patient by saying that the hair will regrow. So it is something that we must be sure about, so the patients will feel comfortable even if a bad thing happened. So I think, George, would you like to add something on? Yes,
I wouldn't agree more. I wouldn't agree more, Marina. Most of these complications do not require a very active intervention from us, other than counseling, appropriate counseling, telling the patient that we may have to wait. This most likely will resolve. Of course, the vision loss was the only one from botulinum toxin that was so rare, and it happened in that case. One needs to refer the patient immediately to ophthalmology and for the appropriate workup immediately, but that's only one case. So it's good though to be aware of that. All aesthetic providers should be aware of this complication because they can happen even though rare, and we don't want to have unhappy patients. We want our patients to be happy.